Today's topic is intestinal obstruction. Basically, there are four cardinal features of the bowel obstruction, which are colicky pain, abdominal distension, vomiting, and obstipation. Initially, the patient present with colicky pain, the abdominal distension will be because of swallowed gas. The vomiting will be projectile bilious vomiting, and obstipation means not passing motion as well as flatulence. In colicky pain, as the time passes, if the bowel goes into gangrene, there will be dull aching pain which will be constant. The causes of small bowel obstruction with having no obstipation but diarrhea will be three cases. First is Richter's hernia, in which the circumference of the whole intestine is not obstructed, so there will be diarrhea. And in gallstone ileus and acute ischemia. The classification of intestinal obstruction will be pediatric causes and adult causes. In pediatric causes, a newborn baby will be affected mainly by the atresia. The atresia may be due to duodenal atresia, jejunal atresia, ileal atresia, and annular atresia, as well as meconium ileus and midgut ileus. The other children's most commonly affected by intussusception, hernia, tumor, and strictures. All these cause the intestinal obstructions. The adult cause of small bowel obstruction will be adhesion, which will be the most common, then hernia, strictures, tumor, and congenital bands. And the large bowel will cause obstruction is cancer and volvulus. As we see bowel distension, in case of obstruction of large bowel, there will be cecum will be distended, whereas small bowel cecum will be collapsed. But if the ileocecal wave is incompetent, this means that it is not properly closing. The cecum will not fully dilated, and its content will move into the small bowel, which will causes a feculent vomit. The pediatric cause. First is intussusception. Intussusception most common is in 6 months to 6 years. As we know that 6 months is a period of weaning period, and in this weaning period there will be hypertrophy or patches because of the rhinovirus infection. This will cause the ileum into the colon. As ileum goes into the colon, it is known as ileocolic intussusception, and we will divide this intussusception into outer tube and inner tube. The outer tube is known as intersuscipiens and inner tube is known as intersusceptum. Clinical features of this 6-month-old baby will be having red currant jelly stool along with vomit and pain, and there will be sausage-shaped mass around the umbilicus, and there will be right ileal fossa will be empty, and this is known as Lardans sign. Investigation of choice for intersusception will be USG, will be represented as a target sign. We will see in subsequent slide. The target sign will be like in this way: Cedar kidney sign and bullseye. The barium enema will show close sign. The barium enema will show claw and coiled spring sign. The management, the most successful management we used to do in clinic, it is USG guided saline or air enema for the young children. For older children and for the adult, we will go for surgery, and in this surgery we will apply pressure from the above. So it's written that we never pull it back from the downward. We will use the pressure from the above so that it will be cured. And the second case is meconium ileus. Meconium ileus, the most common cause is cystic fibrosis. As we know that normally the young baby passed motion within the 48 hours, and if it is not passed, the most probable cause suspected diagnosis is meconium ileus. On the X-ray finding, there will be no air fluid level, and investigation we will give a contrast study, that is gastrographin. And as in this case the meconium get obstructed, this obstruction of meconium in the terminal ileum will cause air fluid level. The first treatment of choice will be Mappic enema, and second line of treatment will be Bishop enema. Bishop loop operation. So in Bishop loop operation, we also known as chimney shaped ileostomy. In this we will bring the distal. Basically in this operation we will bring this distal ileum, and we will form it into a ileostomy, whereas this proximal ileum will be anastomosed to this distal ileum, and That is why it is known as Bishop Coop operation or kidney shaped ileostomy. The other case is malrotation of gut, as by the 6th week from the umbilicus. From this umbilicus, the midgut come out into the amniotic cavity, and by the 10th week it goes inside. But if there is a lad band will not cause its proper rotation. That is why the duodenum will be straight and duodenum will be in right side, whereas the large bowel will be on the left side, and this will cause the vomiting. Whereas in the midgut volvulus there will be clockwise rotation, result in bowel ischemia, and if it persists it will cause into gangrene. Midgut volvulus, the common clinical feature in the newborn. In the midgut volvulus, the clinical feature will be newborn. A newborn, there will be severe pain and bilious vomiting. The investigation of choice will be GI contrast study, and the procedure, surgical procedure, which is LAD procedure, will be done. There it is done in four steps, which is untwisting procedure. Then we will remove that LAD band, and we will keep the small bowel that is up to the ascending colon on the right side, whereas large bowel to the left side, and then we will go for appendix removal, so that in future there might be no confusion. Now there is a large bowel obstruction. It is usually most common cause is a cancer on the left side, whereas second most common is a sigmoid volvulus. There is a cecocolic volvulus and sigmoid volvulus. Cecocolic volvulus most commonly in females, which are most commonly pregnant, and it is a misnomer, as there will be clockwise rotation of both the cecum and the ascending colon, but in sigmoid volvulus it is anti-clockwise. Usually all the volvulus are clockwise, but sigmoid volvulus is only one which is having anti-clockwise rotation. Sigmoid volvulus is usually associated with the old ones, and also with the population taking a high fiber diet, for example like in South India. So if this cecum and colon undergoes anterior posterior rotation, it is known as cecal baculae. On X-ray, there will be coma-shaped colon, and treatment for the cecocolic volvulus will be right hemicolectomy. Whereas sigmoid volvulus, on X-ray there will be coffee bean appearance, and barium enema there will be ace of spade or bird beak appearance. Basically, the treatment of sigmoid volvulus will be decompression and retorsion, and after that we will go for a surgery of colectomy. Now we will discuss the pseudo obstruction of the colon. Pseudo obstruction of the colon, it is because there is no organic obstruction, and it is divided into the acute and chronic. Acute is also known as Ogilvie syndrome, and in this there will be distension, as well as there will be no pain and no passing of the stool for the 6 to 7 days. And in chronic, this is basically due to neurological disorder or self-induced enema in a patients. Treatment for both of these will be colonoscopic decompression, and if it is not responding, we will go for neostigmine injection to the patient, and he will be sit on a commode, and then the feces will be passed. And if there will be not responding, there will be subtotal colectomy, and there will be anastomosis must be done of ileorector. Now there are basically two surgical processes, which are Hartmann operation and Paul Michaelis operation. Hartmann operation, there is a 3 steps must be done. That is, first we will resect that part which is the diseased part of the colon. Then the proximal colostomy will be done, and then the distal part is obscure, insert and must be stayed there, and is known as Hartmann procedure. And after that we can anastomize it. In the Paul Michaelis operation, there will be proximal colostomy must be done, and then after that there will be distal mucous fistula must be formation. So basically there are 2 opening in the Paul Michaelis operation, and in Hartmann operation there will be a single opening. This is known as target sign or pseudo kidney sign or bull eye sign, as seen in intussusception. Second, it is a close sign. Close sign, it is in barium enema. We will show a close sign in case of intussusception. Third, it is coiled spring sign. Coiled spring sign must be seen in barium enema in case of intussusception. Basically, the 2 difference between the cecal volvulus and sigmoid volvulus is seen there.